Hi everybody, it's Nurse Inga here, and we are talking about GI system again, this time intestinal disorders. So this is kind of the second part of the series. This is the lower GI stuff. I hope you guys are all doing well and hanging in there. We're going to start off by talking about intestinal obstructions. These can be upper or lower GI. They can be mechanical, which are things like adhesions, so like scar tissue, tumors, so like cancer or non-cancerous tumors, appendicitis, hernias, fecal impaction, strictures, intussusception, which is where it like telescopes on itself, or volvulus, where it twists, and then fibrosis due to like endometriosis, or even like some vascular disorders where there's like a blood clot or problem like that. They also can be what we refer to as non-mechanical, where we talk about that being like our ileus. So we can get that as a perioperative ileus. We can get that from peritonitis and just kind of inflammation of the gut. And then we can also get it from hypokalemia. Common findings of all intestinal obstructions include abdominal pain, distension, and constipation. So let's talk for just a second about the difference between small bowel obstructions and large bowel obstructions. So your small bowel is the part, like the duodenum, the jejunum, then all of your small bowel that loops around and finally ends in your ileocecal valve, transitioning then in your right lower quadrant into your colon, right? And then your colon is your from your right lower quadrant to your right upper quadrant, your ascending colon, and then it turns at the liver, which is called the hepatic flexure. It goes across the top, which is your transverse colon. It turns in that left upper quadrant at the splenic flexure by your spleen, and then it heads down from your left upper quadrant to your left lower quadrant in the descending colon, and then kind of turns again a little bit and becomes like the sigmoid colon, and then the end is the rectum, and then obviously the exit is the anus. So when we talk about your colon, we're talking about the large intestine, and we're talking about your small intestine or small bowel obstructions. That's kind of everything up until that point. So small bowel obstructions are classified as like abdominal discomfort or pain. Oftentimes the person will have visible peristaltic waves in like the upper or the middle part of the abdomen, especially if they're thinner. You might not see that with somebody who's obese. They might have upper or epigastric abdominal distension and discomfort, and then nausea and profuse vomiting, which may contain fecal material. So you'll hear us refer to that as fecal vomiting, and it smells like feces, and I would be willing to bet it tastes like feces as well. Obstipation is the word for no passage of stool, versus constipation is, having a difficult time moving your stool, and hard, dry stool. Obstipation is the inability to pass stool. Severe fluid and electrolyte imbalances are common with small bowel obstructions because there's such persistent vomiting. And remember that you lose potassium and you lose hydrochloric acid when you're vomiting. And so you have the potential then for a worsening condition, because hypokalemia can lead to an ileus. And then you can also get metabolic alkalosis from the loss of the hydrochloric acid from the stomach. Severe fluid and electrolyte imbalances with these small bowel obstructions, and then the metabolic alkalosis again from the vomiting. So to contrast that, the large bowel obstructions have more of this intermittent lower abdominal cramping, lower abdominal distension, minimal or no vomiting, obstipation or ribbon-like stools, so only a small amount of feces can pass through. No major fluid and electrolyte imbalances, and then metabolic acidosis is more common, not always present. The finding of an obstruction is diagnosed by CAT scan, and then treatment depends on the location. Oftentimes, because regardless if you're having a problem with vomiting or you know, if the person had like diarrhea or something like that beforehand, the IV therapy will contain potassium. So remember, depending on the rate of the potassium, if it's faster, like 20 milliequivalents per liter per hour, or faster, then you're going to want to have them on the cardiac monitor. And typically, we don't go faster than 20 any place outside of like a really good ICU. Some of the ICUs will go like 40. Most of the floors, like med-surg floors, won't go faster than 10 milliequivalents per hour on potassium because it has such a strong effect on cardiac. Monitor fluid balance really carefully in these patients, especially the small bowel obstructions. Mouth care, pain management, coping and anxiety management is really important with these patients. Thinking about your vital signs, you know, looking for signs of shock, you're going to look for that tachycardia, the tachypnea, the hypotension, pale, cool, clammy skin. Assess the abdomen at least twice a day for bowel sounds, distension, and passage of flatus. So eructication is burping, and then passing flatus is, you know, farting. And that's important, right? We want to make sure that people have peristaltic movement and that they're passing gas, even if they're not passing stool yet. Monitor the fluid and electrolyte status, including lab values, so it's really important for you to monitor those electrolytes. And then manage the patient who has an NG tube. So if they have an NG tube in to help kind of decompress the stomach and not put anything else in there that's just going to get vomited out anyway, then you want to monitor the drainage, so the color and the amount. Ensure that the tube stays patent so that they don't get abdominal distension and vomiting around the tube, and then potential aspiration. Checking the tube placement is important. Irrigating the tube if that's written in the orders, and then maintaining the patient on NPO status. Some physicians will allow ice chips even while the NG tube is hooked to suction, knowing that as the patient is, you know, swallowing those ice chips, it's just going to get suctioned back out again, but it does provide some comfort and it does keep the oral mucosa moistened. Remember, when you're doing I&Os, that if you give them a 240 milliliter cup full of ice, that's only 120 milliliters of fluid. So you want to count ice as only half of what you gave them, because ice expands, obviously. Water expands as it freezes into ice. Meticulous, frequent mouth care. If the patient has an NG tube in, then you need to do care of the nair as well and the skin, and make sure that it's secured really well so it doesn't slip. And then patients with NG tubes should be maintained in at least a semi-Fowler's position at all times to prevent aspiration. Analgesics are important for pain as prescribed. And then there's a drug called Entereg that is used in some patients who have the postoperative ileus to help promote peristalsis. Excuse me. And then if the patient is getting parenteral nutrition, so PPN or TPN, then you would want to give that as prescribed also. And we never want to stop that suddenly, because that can have drastic effects on blood glucose levels. Large bowel obstructions can cause some pretty significant problems for patients. They are most commonly start in the sigmoid colon, usually related to cancer, irritable bowel disease, diverticulitis, benign tumors, or impaction of stool. And they develop and progress slowly depending on the location of the obstruction. Typically, the person has constipation that then leads to obstipation, and they'll complain of crampy lower abdominal pain. Again, the outline of the bowel may be visible through the abdominal wall, and with large bowel obstructions that go on for a long period of time, fecal vomiting may eventually result because it backs up into the small bowel and then it doesn't have any place else to go. So peristalsis eventually kind of reverses. So eventually this may also result in dehydration, but it's more gradual than with a small bowel obstruction. The treatment for large bowel obstructions obviously is, NPO, enemas, laxatives. Some large bowel obstructions do require surgical intervention, so they might do like a resection, a temporary colostomy, ileoanal anastomosis, or cecostomy if there's if they're like a poor surgical risk, so they can't go under general anesthesia or for a long period of time. So if the person has a good outcome and they're being discharged, then we want to make sure that we do good discharge teaching with them, and that would include teaching them how to use either like a bulk fiber laxative or add lots of fresh fruits and vegetables into their diet, as well as drinking adequate amounts of fluid, especially water. Really educating people about the detriments of caffeine and carbonated fluids in relation to water intake, and the need to, like, if you drink 8 ounces of coffee, you need to drink an extra 8 ounces of water every day. Same thing, like if you have 8 ounces of a carbonated beverage, you need to have an extra 8 ounces of water. Do not routinely administer laxatives because your bowels can become dependent on those, and those can actually increase the risk of obstructions. The only laxative that's safe for routine use is a bulk fiber laxative, so something like Metamucil. Encourage the patient to exercise regularly if possible, so walking every day is good. Just the movement helps increase peristalsis. So for people who have inflammatory conditions, we oftentimes will have them rest and not walk, or stay in bed as much as possible to decrease peristalsis. For people who we want to promote peristalsis, you want them to get up and walk as much as possible. Natural foods stimulate peristalsis, like warm beverages, prune juice, and again, like bulk forming laxatives like Metamucil. And talk to the patient about checking the stool, the amount, the frequency, making sure that they're not oozing like soft or diarrheal stool around an impaction that exists. And have the patient sit on a toilet or bedside commode rather than on a bedpan for elimination while they're in the hospital, so that they don't end up like straining. Like, you really want to put them in the optimal care or position for elimination. So 2 of the things that can occur that are kind of like worst case scenario side effects of bowel obstruction would be a perforation and peritonitis. And so it would be important to be able to, during your assessment, differentiate between a paralytic ileus and perforation and peritonitis. So the paralytic ileus is that non-mechanical obstruction where the person has this kind of constant diffuse abdominal pain and distension with decreased to absent bowel sounds, and they can have vomiting of gastric contents and bile and not passing any flatus. And typically, again, there's a history of operative, like they're just freshly post-op. They may have peritonitis. They might have hypokalemia or, severe hypotension. So like the patient who's in shock that had a hypoperfused gut might have a paralytic ileus as well. The person who has a perforation and peritonitis, which is an acute inflammatory process will have evidence of inflammatory changes. So this is a sudden, severe, diffuse pain. And sometimes, like if it was an appendix that ruptured, it would have been sudden, severe, localized pain in the right lower quadrant that suddenly got like a little bit better and then became diffuse and worse because it ruptured, so the pressure relieved, so it got better. And then as all of those nasty gastric acids and stomach contents and fecal bacteria and everything else leaked out into the stomach, it started to inflame all of the intestines and the blood vessels and, the fascia, the peritoneum. So all of that gets really inflamed, and that causes then this kind of rigid, board-like, distended abdomen. The person will have rebound tenderness and oftentimes referred shoulder pain. So it hits those phrenic nerves and radiates up to the shoulders as soon as the irritation reaches the diaphragm. Nausea, vomiting, anorexia, so loss of appetite, are common with peritonitis, as well as signs and symptoms of shock. So tachycardia, tachypnea, hypotension, significant fever, and decreased urinary output, all showing you that the patient's not doing well. And then decreased bowel sounds without passage of flatus or feces, which again, perforation and peritonitis can cause the paralytic ileus. So what is really the defining factor? Well, you want to think about that initial onset and presentation. So what caused it, but then really look for those signs and symptoms of sepsis and shock. So is the patient tachycardic and febrile? Do they have that rigid board-like abdomen? Is there a good story here of, a rapidly changing pain presentation or abdominal assessment that leads me to believe that this is a perforation or peritonitis? And if that is present, then that's definitely somebody that needs a rapid response. Call the surgeon. That's not a patient that you want to just sit on and monitor. So as we said, colorectal cancer is one of the leading causes of large bowel obstructions, but let's just talk about kind of cancer in general. So cancers of the colon and the rectum, so the large intestine, are one of the most common types of cancers in the United States. And risk factors include age, so as you get older, genetics, so there are certain genes that make you predisposed for this cancer, a family history, and that's really strong. So somebody who has a family history of colon cancer has a much higher chance of having colon cancer. A person who has polyps on their colonoscopy, a person who has Crohn's disease because of that kind of chronic dysplasia, so that chronic irritation of the lining that becomes cancerous. Ulcerative colitis, it rarely would become cancer, but it's possible. Obesity, tobacco use, physical inactivity, and heavy alcohol use, as well as diets that are high in animal fats or fried food, refined carbohydrates, are thought to contribute as well. And this is oftentimes referred to as like the carcinogenic diet, so low fiber, high fat diet. And we know that that contributes to GI cancer. Screening for colorectal cancer includes fecal occult blood tests, so doing a stool test to screen for blood, colonoscopy or sigmoidoscopy, and barium enemas. And then treatment for people who have been diagnosed with cancer includes chemotherapy, radiation, and surgery. So the types of surgeries that we do include a colon resection, a colectomy, or we can do a colostomy. So here you see a colectomy where a portion of the colon is removed, and that can be open or laparoscopic. And when this happens, this is our colectomy, the patient has relatively normal bowel function preserved. So like in this case, they showed you they had removed from here to here. So this would be the splenic flexure and the descending colon, and then they reattached and kind of changed the shape and the location of the large intestine, so they re-anastomosed it. This is not an uncommon surgery also for patients who have like a diverticulitis. Then over here we have a colectomy or proctocolectomy, where normal bowel function can be affected, and this is where the colon is removed, as well as so the entire colon is removed, as well as here just the colon, but the rectum is preserved, and then the ileum is connected to the rectum. So you see that the ileocecal valve, which is where your appendix is disconnected. So you take off the cecum, which is the start of the large intestine, as well as the vermiform appendix, and then the ascending transverse descending colon, and kind of the sigmoid colon, so this area through here, but reserve the rectum itself and the anus. And then for this, the person then just has fairly liquid stool initially, and normal bowel function can be affected because, you know, this the large intestine is where the fluid and some of the nutrients, vitamins, are taken up. Eventually, this lower part of the small intestine, so that distal end of the small intestine, will eventually kind of take over the role of the colon and will start to absorb some of that liquid and some of those nutrients. And, you know, eventually this person will do okay, and they'll probably be continent. And then the other thing that's an option is to create what's called a J pouch, so that you don't have all this pressure of all this liquid stool kind of pressing on the you know, sphincters of the rectum and the anus all at once. And so this creates kind of a reservoir or a pouch here that helps with continence. So this is an ilioanal anastomosis, where we create this pouch, and that's when the rectum itself is removed, and you're creating kind of, again, a fake kind of pouch in that area for storage of fecal contents prior to evacuation. So colostomy management is pretty important, and you want to teach the patient after surgery about their new ostomy. Assessing the color and the integrity of the stoma frequently is really important. A healthy stoma should be reddish pink in color and moist, and protrude about 3/4 of an inch, which is about 2 centimeters, from the abdominal wall. It will shrink a little bit over the next 6 to 8 weeks, so the appliance will probably need to be remeasured. And it should start functioning in about 2 to 3 days. So initially the person won't have any stool out of there. So the person may need to be NPO and have an NG tube initially. They may need TPN or PPN, depending on how long they've been NPO before the surgery. And teach the person about emptying the bag when it's about 1/3 to 1/2 full of stool, and avoid gas-forming foods and beverages, reporting pain, cramping, nausea, and vomiting. Patients will have a lot of questions about, you know, the things that they identify with most. So whether it's, you know, activities or work or, you know, sex, intimacy, whatever it is, you know, however this is going to impact their life most, those are the things that they're going to have questions with. So you really want to address the questions that they have and make sure that you get an ostomy nurse consult, so that, you know, they can also have like the best plan of care from the start. So collaborative management is really important as well. If the stoma, so the nice beautiful red part in the middle there, starts to look dusky at all, that is a surgical emergency. That means that it is not getting adequate blood flow, and you need to let the surgeon know immediately. Mucus is normal to drain from the rectum after surgery if the rectum stays patent, and the patient should be educated about that, you know, they still need to do hygiene in their peri area and kind of clean things up, and then monitor I&O, and that's important as well. So again, for all patients undergoing bowel surgery, and so moving forward as we talk about some of the other conditions, this is also going to be important, but the patient may need to be NPO for several weeks before and after. TPN can provide nutrition. Remember that TPN goes through a central line. We don't do that through a peripheral line, and it has all sorts of regulations. We, as a class, if you're in my class, are going to talk about nutrition next week. So we'll focus more on that later. Monitor vital signs and I&O very carefully. Labs, H&H, so your CBCs, white blood cell counts, looking for any evidence of bleeding or infection. SED rate to look for inflammation. Managing pain is pretty critical. Wound care and abdominal assessment, NG tube care, all these things that we've talked about. Complications, again, bleeding, leaking, anastomosis. The stool would leak into the peritoneal cavity. That would cause peritonitis and sepsis. Perforation is possible, and then wound dehiscence and infection. So just watching for, again, pain, cramping, nausea, vomiting, any evidence of bleeding, infection. Thinking, I always like to think about it as like the worst case scenario, the what if, what's the worst thing that could happen, and then making sure that I am mentally prepared and watching for those things so that I will recognize them if they do. Irritable bowel syndrome, or IBS, is chronic recurrent diarrhea, constipation, or both, abdominal pain and bloating. The patient usually complains of like pain, gas, bloating, constipation, diarrhea, and they can either be one or the other or both, or it can alternate. Diarrhea tends to be worse in the morning after breakfast, and the patient might feel weak, faint, or even have palpitations. A lot of times they have abdominal bloating with or without observable distension, and patients with IBS tend to feel better once they go to the bathroom. So they a lot of times have this left lower quadrant like pain and discomfort that once they defecate they feel better. This tends to be triggered by stress, food, and visceral sensations. So when the stool is in the GI tract and it gets full, it forces them to have a bowel movement, but sometimes also other pain can trigger this as well. Dietary fiber can help regulate stools regardless of whether it's constipation or diarrhea. It's chronic and incurable, so we don't really know the cause. It mainly affects the intestines, but in some people it has more systemic effects than others. So treatment is pretty individualized. We try to decrease stress and anxiety. Probiotics have shown to be helpful in some patients, and then herbal remedies as well. If patients have certain trigger foods, then we teach them to avoid those. And then some drugs like antidepressants and antidiarrheal drugs can be helpful, but there are drugs on the market that specifically target IBS-C, which is the constipation, and IBS-D, which is diarrhea, that seem to be pretty effective. So we're helping patients more and more kind of pinpoint what exactly their primary problem is and then treat those. So stress management, diet control first, and then medications are available to treat the symptoms if diet and stress management don't help. Moving on to hernias. Protrusion of a segment of bowel, fat, or other tissue through a weakness in the abdominal wall, diaphragm, or other abdominal structures. And you see here that the most common sites are inguinal, femoral, umbilical, incisional, or we call it ventral. This is caused by muscle weakness and increased intra-abdominal pressure from things like obesity, pregnancy, and lifting heavy objects. And basically it forces whatever's going to herniate through these weakened areas, and it's either reducible, where it goes out and it can come back in, so the contents can be placed back into the abdomen with gentle pressure, or it's incarcerated, which is irreducible, so it can't be reduced with pressure, and attempting to reduce it can be very uncomfortable, to say the least, for the patient. Or it could be strangulated. Now, strangulation of a hernia is a surgical emergency, and that is where the swelling occurs either in the incarcerated part or in the opening that the intestine or whatever has come through, and it has swollen to the point or narrowed to the point where the blood supply is now cut off. And so this results in intestinal obstruction, gangrene, necrosis, bowel perforation. So the symptoms are like severe pain at the site of strangulation, nausea, vomiting, colicky, abdominal pain. If it is bowel that is strangulated, it acts like an obstruction. If it's something else, then it's just severe abdominal wall pain. So looking for nausea, vomiting, pain, fever, tachycardia, abdominal distension. Again, true surgical emergency, call the surgeon right away. The worst one of these I've ever seen actually was about 6 feet of small intestine that had gone into somebody's scrotum and had made this ginormous scrotum and then had torsed on itself. And so it was not a testicular torsion, it was actually a small intestine torsion inside somebody's scrotum, and it was large and discolored and incredibly painful, and required emergent surgery. Prevention really is key. So we want to improve abdominal musculature, use safe lifting techniques, and use supportive binders for heavy lifting, and then when needed, surgery. So there's surgical repair with or without mesh that could be used to replace the hernia and fix the abdominal wall. Post-operatively, all of the normal things, gag reflex before you start feeding them PO, ensure that they're passing flatus before you start feeding them, and then for especially male patients, but for all patients, we want to make sure that they void prior to discharge. Men especially have a predisposition for acute urinary retention related to anesthesia. Hemorrhoids are varicose veins in the anal region that occur from an increased intra-abdominal pressure that cause dilation in the anal canal. They can be external, where they start on the external surface and enlarge. They can be internal, where they start inside, or they can be prolapsed, where they start inside and then kind of stretch out through the anal ring and kind of hang out. So there's different types: internal, external, and prolapsed internal. Signs and symptoms include itching, bleeding, pain with bowel movements, and anemia is possible if they're severe and persistent. They can be caused by things like constipation, straining, obesity, heart failure, pregnancy, and prolonged sitting or standing, like nurse life, and heavy weightlifting, and that includes patients. Prevention of constipation is the primary intervention, and again, bulk-forming laxatives are approved for long-term use. So we want people to increase fiber and fluid, ideally from natural sources like fresh fruits and vegetables and water, but if that's not possible for whatever reason, then a fiber laxative is fine. Ambulation and maintaining a healthy weight is also key to preventing constipation. For medical management, we can use topical treatment. So they're like preparation H or steroids. There's suppositories, and some are just like lubricants, and others are steroids. And then stool softeners also can help keep, like Colase can help just keep the stool soft and prevent straining. Surgically, there's a hemorrhoidectomy. After surgery for hemorrhoids, you need to monitor for bleeding, pain, and infection. Depending on where the hemorrhoids are and the extent of them, this can be an incredibly painful process. So post-operatively, it's critical that somebody should be with or near the person during their first bowel movement, because it's not uncommon for people to have a syncopal episode during the first bowel movement from pain. Astringents like witch hazel I didn't mention, and then sitz baths as well. If you like witch hazel, you can keep it in the fridge or keep it cold, so you can teach people that, and then they can apply it with a cotton ball. Teach them about not contaminating the bottle, and then cryosurgery, sclerotherapy, rubber band ligation, and hemorrhoidectomy are the different types of surgeries that we use to manage our hemorrhoids. All right, so those were kind of our non-inflammatory intestinal disorders. So moving on to talk about some inflammatory conditions that can occur. The first is appendicitis. And appendicitis is an acute inflammation of the vermiform appendix, which we talked about, where that's located right at the ileocecal junction. So it's just off of the start of the large intestine. The most common cause of appendicitis is stool obstruction, so constipation. And then that can actually form what's called like a fecalith, like a stone made out of poop that forms at the opening of the appendix, and or stool itself can kind of plug the opening if the person is impacted there. And that causes a backup of the fluid that's secreted by the mucous membrane inside the appendix. And the fluid accumulation then can become infected. And if it's obstructed, then that leads to necrosis, and then inflammation, swelling, and perforation of the appendix. So the most common presentation is this kind of peri-umbilical pain that then moves to McBurney's point, which is 2/3 of the way from the umbilicus, so the belly button, to the anterior superior iliac spine. So it's about where you would normally put your stethoscope to listen in the right lower quadrant. Rebound tenderness is the most common. So when you push in, the patient may experience a little bit of tenderness, but when you let go, the tenderness is more severe. At the kind of general RN level, we don't necessarily assess for rebound tenderness if you suspect appendicitis, because our concern is for perforation. So instead, what you could do to assess for rebound tenderness is ask the person if, you know, the bumps in the car ride hurt them. You could ask the person if they have pain lifting their right leg up in the air. So anything that engages the psoas or rotation of that right leg, the psoas muscle runs right underneath that inflamed appendix. That's going to increase the pain. But really the other thing that you can do is just take your hands and put them on the flanks of the patient and kind of jiggle the flanks a little bit, and that will send kind of shock waves, if you will, moving through the abdomen, and it will wiggle the appendix and it will hurt, right? So if you cause movement of the appendix when it's inflamed, it will be painful. So rather than, you know, actually pressing in and letting go, which could cause a perforation or rupture if, you know, it's very inflamed, you can safely kind of percuss the flanks and cause rebound tenderness. Fever is very common. When people have perfed, the temp is usually at least 100. The white counts are usually like, you know, 22,000 or greater. Like, we're talking about pretty significant white counts. And then nausea, vomiting, and anorexia are also common. So right lower quadrant pain, nausea, vomiting, fever, and then leukocytosis and elevated white blood cell count are all really common with appendicitis. The diagnosis of appendicitis is determined by CAT scan or ultrasound. Typically we do an ultrasound, and if we can't see the appendix, then we kind of get stuck doing a CAT scan, but you can't see a normal appendix on ultrasound. So we can kind of use ultrasound to rule in appendicitis if you can see it, but you can't really use it to rule out appendicitis because we can't usually get a clear picture saying that the appendix looks normal with an ultrasound. If it's not perforated, then a lot of times the patient will go for surgery. Now, some surgeons actually are opting for more conservative measures where they're admitting patients and doing IV fluids and antibiotics and seeing if they can get the appendix to kind of chill out and not removing them. It's certainly safer for the patient if the appendix is removed when it's not massively inflamed and there's an infection present. So if that's possible, then you know, that's an interesting or I guess more safe approach. And then if it is perforated, surgery oftentimes is delayed for IV fluids and antibiotics. But again, these are all kind of on a case-by-case basis, because if it's perforated and the patient's septic, then they may want to open them up and clean them out. And then some of those I've seen healing by you know, they leave them open. They don't even close them. They're allowing it to drain. You know, we're doing like massive wound packing, and there's a lot of drainage and discharge. Abscesses can occur also, and those are treated with parenteral antibiotics and drainage of the abscess if an abscess occurs on or near the appendix from the infection. All right, so again, periumbilical pain, kind of moving to the right lower quadrant. It's super important to keep these patients NPO because of the, you know, risk of needing to go for surgery emergently if they need to. You don't want to put anything in the stomach that could then mess with the anesthesiologist's view of the airway if they vomit. Tylenol for fever. IV fluids and antibiotics and pain medication are all appropriate therapies for managing these patients. Semi-Fowler's is the position of choice to contain drainage in the lower abdomen in case it does perforate. That way it doesn't spread throughout, and it would slow down the progression of peritonitis. Also, you know, the patient tends to feel more comfortable with a slight bend at the waist rather than stretched way out flat, so they tend to be more comfortable that way. No heat, no laxatives, no enemas. All of those things can actually increase the likelihood of perforation and peritonitis. So those are no's. And then since we know that peritonitis is a risk, we're going to monitor for peritonitis. So again, watching for those acute signs and symptoms of, that pain that suddenly gets worse and then maybe gets a little bit better and then spreads throughout the abdomen with that rigid board-like abdomen and distended abdomen. The pain can radiate up to the shoulder sometimes. Nausea, vomiting, fever, tachycardia, signs of shock, and inability to pass gas or feces. Hiccups also are possible because of irritation of the diaphragm with peritonitis, but just, keeping an eye on, they can rapidly develop septic shock, which can be fatal if they develop peritonitis. So just making sure that you keep an eye on those patients. All right, moving on to chronic inflammatory bowel disease. We're going to talk about ulcerative colitis and Crohn's disease. So ulcerative colitis begins in the rectum and spreads backwards towards the cecum. The person typically has about 10 to 12 liquid stools a day that contain blood. And hemorrhage and nutritional deficiencies are common with patients with UC, and surgery is rare. With Crohn's disease, it begins in the terminal ileum, and then the patchy involvement can occur throughout all layers of the bowel. We call that transmural. So it's not just the mucous membranes, it's throughout all of the layers. And they can have typically 5 to 6 soft, loose stools per day, no blood typically in the stool. And they typically will have fistulas. So fistulas are more common with them, as well as nutritional deficiencies. And surgery is fairly common with Crohn's disease. So one of the ways that you can kind of remember these, and obviously I have to include pictures, is ulcerative colitis, UC, impacts the mucosal edema, or impacts the mucous membrane and causes mucosal edema. So the UC is there as well. Again, so this is ulcerative colitis, the widespread inflammation of the rectum, the sigmoid colon, the mucosal lining bleeds. So you could just see here how irritated it is, and it bleeds and it ulcerates. Abscesses can form, necrosis can occur. The person usually has like this kind of colicky lower abdominal pain, and frequent watery stools that are bloody. On labs, you might notice that they have markers that are consistent with increased white blood cells with the inflammation, increased inflammatory markers like your SED rates, and then they would have lower electrolytes because of the constant diarrhea. So they're increasing their losses of like potassium and sodium. Medication treatment for ulcerative colitis includes drugs like sulfasalazine, which is an aminosalicylate. And sulfasalazine is actually a pretty effective drug, but one of the things that you need to know about it is that it decreases absorption of folic acid. So patients need to take folate supplements while they're on the sulfasalazine for ulcerative colitis or Crohn's disease, because you can use it for both. Steroids also can help. It decreases that inflammatory response. Antidiarrheal drugs help retain fluid and stool, and immunomodulators also can help. Patients in severe cases sometimes have lost so much fluid, they're so extremely fluid volume deficit that we end up making them NPO and putting them on TPN. They do have an increased risk of colon cancer, as we pointed out before, so they should all get regular screenings. Whether they have ulcerative colitis or Crohn's disease, they need like regular colonoscopy, frequent screenings. They can get, with ulcerative colitis, what's called a toxic megacolon. They can get hemorrhages, perforations, again, a cancer, so they may require surgery, but not as often as Crohn's disease. An ileostomy is often used for ulcerative colitis if they're going to do anything. And they also could do a restorative proctocolectomy with an ileo pouch and anal anastomosis. So that's called an RPC-IPAA, and that's considered the gold standard surgery for ulcerative colitis patients. It's a two-step procedure, so they go in and they first create this collection pouch, and then they later kind of reattach that to the intestines and the anus. So they basically kind of take out the entire colon, and then they create that pouch with the ileum to collect stool. With these patients, again, they have removed the rectum, the colon, the anus, the anus and the anal sphincter remain intact. But the terminal ileum, which is about like 1.5, the end of it, the 1.5 feet at the end of it, creates that reservoir, and then that gets sutured to the anus. So it's essentially replacing the collection duct, like it creates a pouch to hold the stool. And again, with these patients as well, the small bowel will eventually kind of take over what the large bowel had done, will start to absorb liquid and start to recapture some of that fluid. So after the surgery, the risk of fluid volume deficit decreases slightly. They'll improve usually if they have that surgery. But fluid and electrolyte imbalance is still huge with these patients. And you want to do good teaching about management of the ileostomy. So that includes skin protection, the pouch care, nutrition, medication therapy, and then reporting any problems at all, and checking the stoma to make sure that it stays that nice beefy red, and reporting it immediately if it becomes dusky. So Crohn's disease gets cobblestone, and Crohn and cobblestone kind of rhyme a little bit, but Crohn's disease gets this really cobblestone appearance, and this is, again, chronic inflammation of the small intestine, the colon, or both, and it most commonly affects the terminal ileum of the small intestine, and it's transmural, which means it goes through all of the layers. The inflammation leads to thickened bowel wall that causes strictures and then deep ulcerations, causing this kind of cobblestone appearance. Because of all of the kind of erosion and ulceration and then scar tissue, fistulas are really common in Crohn's patients. So again, lesions of the terminal ileum, they extend through all of the layers of the colon with fistulas. Abscesses are common, perforations are common, and they have loose stools. They can get anemia, malabsorption issues. The same medications are used for Crohn's disease as for ulcerative colitis, or the same types of medications. Surgery, while it's more common, is less effective for Crohn's disease than ulcerative colitis. Sometimes they have to remove the entire small intestine, and then the person really has malabsorption issues. Skin care is really important if fistulas are present, And strictures, so like narrowing of parts of the intestines, can lead to complete obstructions. Remember with both of these patients that diarrhea equals potassium loss, which causes cardiac arrhythmias. So with all of your patients, if they are hypokalemic, they need to be on a cardiac monitor. That's like a huge safety concern. This is just a picture of fistula. They can be between two like organs, like intestine to intestine, intestine to bladder, intestine to vagina, or they can be between the intestine and the external world, like intestine to skin. All right, diverticulitis. So diverticulitis and diverticulosis. Diverticulosis is just the condition of having these out pouches. So diverticulosis are little herniations of the intestinal wall, or little out pouches in the intestinal wall where the person is usually asymptomatic. So diverticulosis is not a problem in and of itself because the person is usually asymptomatic, but it does put you at risk then for developing diverticulitis. And diverticulitis is when you get food or bacteria or stool or whatever stuck in these little out pouches, and the bacteria in them then kind of fester and grow, causing inflammation and infection, and then that becomes very painful. So that can lead to then perforation, abscess, fistulas, obstructions, and bleeding if not treated. So the person experiences left lower quadrant pain, nausea, vomiting, and fever when they have an infection in their left lower quadrant. Antibiotics like Flagyl, Bactrim, Cipro are used to treat the infection, but it's important not to use laxatives or enemas because that actually increases the risk of perforation. Rest, a low fiber diet when you start eating again is important, as well as hydration. So when we progress them from NPO, it goes like NPO, like, clear liquids, full liquids, and then we go to low residue. And what that means is, like, if they're going to eat meat, it needs to be ground beef, and if they're going to eat bread, it needs to be white bread, believe it or not. We want them to have low residue, so we want them to have things that can be broken down as easily as possible, and we want them to chew their food as much as possible. So we want things that are not high in fiber or high in like residual pieces, so no like corn, nothing with like husks or skin or seeds or anything like that initially while we're progressing their diet. There's no good evidence that says that people with a history of diverticulitis or diverticulosis can't eat nuts and seeds and berries and stuff like that unless it specifically irritates them, and then they shouldn't. But as a general population, there are not diet restrictions with diverticulitis except during the acute flare-up and in the recovery phase. So it's really critical that we monitor for signs and symptoms of perforation, abscess, obstruction, and fistula. So you're looking for pain, fever, bleeding, and shock, because complications of diverticulitis can be kind of like sudden and severe. So to manage diverticulitis in the long term, prevention of constipation is really the key thing. The constipation is what kind of forces the stool into those pouches. So you want to keep people on a good regimen of normal bowel habits, foods that are soft, high in dietary fiber, normally prunes, peas, bran, things like that, and avoiding foods that may cause obstruction. So if they get really like constipated if they eat like a lot of red meat or a lot of rice or a lot of cheese, then we don't want them to eat those things. Oral antibiotics can be used if the person isn't sick enough to be admitted, or IV antibiotics and pain control if it is severe. Antispasmodics might help with the pain. Tranquilizers is, not a great way to say that, but, benzodiazepines, drugs like that help take away like the anxiety also may help. And then surgical resection with anastomosis or temporary colostomy to rest the colon also can be used in patients who have really significant severe diverticulitis or who have ruptured. So diverticulitis also can result in lower GI bleeding, polyps, anal fissures, hemorrhoids, IBD, and cancer all can cause lower GI bleeding. So upper GI bleeding is when you have bleeding like in the stomach, and that results in like the coffee ground emesis and the melena, that black, thick, tarry stool. Melena typically has been in the GI tract for at least 8 hours. The acids in the stomach denature the protein and turn it into that, like break down the blood and turn it into that kind of thick, kind of like, you know, iron smelling stool. When you bleed in the lower GI tract, that's an alkaline environment, and so you get more what we call hematochezia. So hematochezia is bright red bleeding from the colon or the rectum, or you might get like maroon stool, or you might get ribbons of blood in the stool, or like, you know, like big clots of blood in the stool. But true like blood that you can recognize as blood is a sign of a lower GI bleed, and that thick, nasty, black, tarry melena stool is a sign of an upper GI bleed, like your peptic ulcer disease, your esophageal varices, things like that. So for testing for lower GI bleeding, we would do a hemocult. Obviously, the doctor would do like rectal exam. You know, colonoscopy would help determine what's causing it. But in the short term, getting a complete blood count to look at the H&H is important. Looking at the BUN and creatinine for fluid balance is important. And then depending on the cause, you know, if it's just inflammation, it might be gut rest. If it's infection, it would be antibiotic. If it's a polyp, it might be removal. If it's cancer, then, you know, we're talking about surgery. And last but not least, anal problems. So anal fissures are tears in the anal lining, usually caused by things like constipation, diarrhea, Crohn's disease, or trauma. And consider in our nursing realm suppositories and rectal temperatures as being trauma. So we can cause anal rectal fissures, we can cause abscesses. This is, you know, significant. And one of the reasons that we've moved away from anal temperatures in babies is because we were actually doing injuries. So these can be acute or chronic. Anal fistulas are abnormal tracts that lead from the anal canal to the perineum, and most often the result of an anal rectal abscess. So an anal rectal abscess then is an abscess in the anal or rectal region, and they're usually the result of plugged ducts of the glands, and they get plugged by like feces or by, you know, swelling of tissue from trauma, and these cause then pain, fever, swelling, drainage of the pus, and bleeding. And in patients who are immunocompromised, they can actually cause sepsis and then death. So in anybody who's immunocompromised, you know, nothing by rectum is a really important rule of thumb. These are treated as needed. So, you know, if it's a fissure, it's hygiene and, you know, anusol or whatever. If it's a fistula, you know, it might be surgical. If it's an abscess, it's I&D, and, you know, sometimes more involved surgery than that, like with packing and things like that. But really keeping it clean, hygiene is probably the most important thing, and then avoiding the trauma, so avoiding the constipation. All right, so to summarize, your brain is your greatest tool. Can't stress this enough. When you're dealing with abdominal and GI things, this is probably one of the hardest body systems, because you can't see it and you can't feel it, and you can hear things, but It's different than heart sounds and breath sounds, and you can't recount it and you can't quantify it or qualify it as well as anything else. It's not the same as a broken leg or the same as a heart attack that you can see on an EKG, and it's not the same as wheezes that you can hear on breath sounds. So you have to know those landmarks. You have to know where the body structures are, and you know the difference between right lower quadrant pain and right upper quadrant pain. Learning the clinical presentations is absolutely critical. So what are the sets of, you know, signs and symptoms that go with each of those disease processes? There's nothing more important, because you need to be able to recognize excuse me, what's right or what's, you know, expected versus what's wrong. And again, expected. So if I say it's possible to have perforation and peritonitis as a complication of many of these, then I'm always watching and monitoring for perforation and peritonitis. But if I just ignore the fact that those are possible, then I will get caught, you know, with my gloves down. Anticipate those risks, always thinking about what's the worst case scenario, what do I need to do to prepare, what do I need to have in the room. You know, if you are going to be a well-organized, good nurse, that's really critical. Educate your patient. Your patient is your strongest team member because they're always in the room. So if they know what to watch for, they are going to be the person who's going to report to you fastest, because they're also the person who should be most invested in a good outcome for the patient. So always let the patient, the family, whoever know what it is that you're looking for so that they know what to tell you. And then above all else, safety is always key. So know, am I most concerned about airway? Am I most concerned about nutrition? Am I most concerned about fluid? Am I most concerned about electrolytes or acid balance? You know, always thinking about what is my biggest concern. Am I concerned about falls? Am I concerned about, you know, whatever. Again, your brain is your greatest tool, and you know how to use it wisely. So carry it with you everywhere you go is my best advice. All right, thank you as always for watching another hour of your life. And you know, since we're all learning from home these days, do me a favor and leave me a comment where you're studying, and I'd love to see where people are listening in from. All right, take care.